ERTC means quality of life means they are working, but they are having so many domains, and for each domain, he is working in the breast cancer, and breast cancer 10 statistician working on the breast cancer quality of life. So it's a big thing over there. But here, whatever the quality of life data, or at least the ERTC data we have seen, and the real challenges we have seen, try to overcome those challenges. And here Ankita is working with me, Ankita Paul. She is working with me. So I am giving her guidance, and she is making this QL MIS package and for repeatedly measures quality of life. So why the repeatedly measures quality of life? Because once we are taking the patient's quality of life data, it takes the first visit, first month, second month, third month, repeatedly we take, and sometimes what happens, the common phenomena we face is every time every patients don't fill their forms, fill their all the questionnaires. I am talking about questionnaires of the related to ERTC questionnaires. So they were never fill those things. So in that sense, while we don't have that full observations, and we get stuck on that, because what to do with that missing observations, not fill up observations. So to overcome that challenges, as well as the conventional or the existing challenge, that how to analyze the quality of life data. So these things we are working on that. It's presents. We didn't. It has not been uploaded in CRAN until now. It's not been peer reviewed now, but it's in process. So I thought to share with that. So there are no specific definitions of quality of life. So few assumptions of the quality of life are to be considered. It's a subjective construct which is not directly observable or measurable. It is composed with multiple dimensions that consist of different characteristics of physical and psychological well-being. And obviously, it's a time dependent, and what happened the patient with after 1, 2, and 3 months consecutive visits, that's are being taken care. So one of the generic questionnaires for ERTC QL is a QL 30 questionnaires are there. These codes are, it comes with a 4 response scale ranging from not all very much except the last 2 questions. So question number 29 and 30, these are having 7 options. Rest are all having the 4 options. So we prepared this ERTC and QL MIS package to present the R functions that can easily work with the different subdomains of ERTC questionnaire, in addition to the presence of missing data and repeatedly measured QL data. So that interest I would like to share that challenge is quite often faced by Dr. Bijay, and he asked me to work on that, and that the existing packages were not there. Whatever was there in R, that is now obsolete. So he asked me to make work on that. I think you forget when he told me. It was nearly 1 year back. He told me we have to make on that. So we started on that. So if you say that QL 30 is having the questionnaires 5 domain or subdomain wise questionnaire, physical domain, role functioning, and cognitive, emotional, and social functioning, and symptom scaling like fatigue, nausea, pain, dyspnea, appetite, diarrhea, constipations, financial difficulties, and global health status. So basically the 3 domains are there. So and 3 domains takes different way of calculating. So raw score for item wise, if you are having the 28 questions, so from 28 questions, or if you are having the particular domain 4 questions, so 4 questions average value should be there. And also for functioning scale are having different way for calculating the score, and the symptom scale are having another way to calculating score. So these are the different formulae to have calculate the different score. Range is different between possible maximum to minimum value in the ERTC questionnaires. So you have to see what is the range, and while we are entering the data or to fill the questionnaire, you have to be always cautious that value should not be more than 4, or it should not be less than 0 or 1. So that is very critical stuff, always need to be kept in mind. So here, as I see that 3 types
no, just go back to the previous slide. Yeah. So understand, when you do quality of life analysis, it becomes very complicated. The ERTC quality of life, as I showed you would have physical function, emotional function, social function, and there are 30 questions in the C30, and there will be domain specific, like head neck will have different questions, brain tumors will have different. So among those questions which are 30, as he pointed out, 29 and 30 actually talk about the global quality of life. Rest 28 questions are jumbled up questions of physical, social. So it's not like that first 5 will be talking about physical, next 4 will be talking about. There will be first is physical, sixth is. So that jumbled up question. So when you take the raw scores, see here it is written that's domain wise. So the raw scores, like for physical function, there are 5 questions you need to take for those 5 questions. For emotional, if there are 7 questions, you need to take the raw score for those seven questions. So if you want to do it manually, this is the way you would remove the ERTC guideline. You will see, okay, these are the 7 questions. I'm just giving you an example. I don't remember at the back of my hand how many questions are the emotional. These 7 are the ones who are dealing with emotional function. Let me add up with this. Then you see there is a division by the number of questions which they were there. And with this raw score, then you need to decide whether your score is one of the functional score or whether it's a symptom score. Now, functional score means emotional function, physical function, social function. Symptom score means when you go to the domains, you have question like pain. So there will be 3 or 4 questions which will be about pain. There will be a few questions, jumbled up question for diarrhea. There are a few questions which will be jumbled up for nausea, vomiting, this kind of symptom scores. There is an global health skill, that is question number 29, 30. See, the scoring is different for them. The scoring is different. The scoring here is raw score minus 1 upon range, 1 minus into 100. The scoring is different for global health scales and for the symptom scales. And what this means is that the higher the score, the poorer is for this. The lower the score, the better is for this. Okay, so the interpretation also becomes different. So see that there is a now doing this manually, by the time now you have understood, it is a headache. Because for one patient you would have one line at baseline, 2 months, 4 months, 6 months, 8 months. Then for the patient to again to do this course at every iteration, it becomes difficult. Again, interesting things comes is few of the scores would have 4 values, like let's say mild, moderate, severe, very severe kind of thing. Some have 7 time points, like not 7, yeah, very little, very little, something of this distributed. So the range actually is the lowest value minus that. So if there are 4, the range comes 3. If there are 7, the range comes 6. So this needs to get divided by the appropriate range, and then you get that score. And then that score needs to be taken forward to compare multiple ways. One can be in the same patient, what was the score at baseline, what was the score at 2 months, what is the score at 4 months, which would differ. It can also be between 2 arms, how the scores have gone between the 2 arms at baseline, at 2 months, at 4 months. Okay, so you could do variable type of analysis with this kind of scores. Doing this manually is a hell lot of job, and Nandini can vouch for it. She did one of such analysis trying manually. I actually made her do it just to understand how common it takes around. It took her around 9 months, yeah, or 1 year. So it's difficult, and that's where
difficult plus
errors, manual mistakes and error prone, and that's where it is a welcome thing if you have codes available which are pre-made. You can directly go for the analysis. Okay, so that is what you can overcome. You can do it in SPSS also, but then there's a syntax to the SPSS which URTC again you need to copy that syntax and adapt with your data. Okay.
So again one intention is again intention is that again to make the simple single line functions, we can overcome that challenge or not. So there we are providing the three functions, that RS function, FS function and SS GS function. For 7 score, 7, 29 and 30th numbers questions, the SS underscore GS function will work. And for physical, for this systematic scaling, these FS will work. Functional scaling, the FS will work. And for calculating the RS will work for calculating the raw score over there. So the single functions name as, and all this can be considered under the umbrella of called QL, Miss QL, and Miss patients and Miss underscore patients. These are the three functions are used. The function of this is to take the entire data in as an input, then consider only those columns that contain the data of the 30 questionnaires. So you can give the entire data set in addition to that the 30 questions, but it will only consider this respective the 30 questions, and thereafter it will create the data frame and will give us the domain wise score value. So it's works like this. So basically the function of QL will considers, the function of Miss QL will considers the repeatedly, sometimes as I mentioned that some questions for one individual particular visit data is not available. So what happened in the while you are entering the data, sometimes we put 9, some are 99, some are NA. So function with Miss underscore QL can take care of that if you understood that data is mixture of 9, 99 and NA. But if you say that okay, I want to overcome, I want to consider only this available information. If a patients are having some partial information, partial visit information and rest things are not there, I want to discard those patients. I want to do the complete case analysis, means only the patients are having full observation I am going to consider, then patients underscore missing function would work over there, and these functions, umbrella functions, all these are considered the questionnaire columns or questions from Q1 to Q30. Thereafter they make the functions called compute the raw score, and from that raw score they make the functions called, it makes the function score, compute the functional scale, it makes the compose the symptom scale, and after that it makes the global scale, global standard. So for this rest 29 and 30 questions. After that we'll get the output data, it will give us the output data with all scoring mechanism calculating the all scoring value. So after the simulated, and now only one thing is that we also provide the simulated data to understand that, to have understanding or get an understanding what kind of, how the data should look like. So as a result, after the simulated data is passed to the QL or a Miss QL or Miss patients, Miss underscore patients functions, so it will give us the domain wise score value, and a matrix dimension of 100 or 30 is obtained. So as a simulated data part we are talking, we generated the simulated data. I'm not going, it may not be much more interest on that. So one thing is that there are different types of, these are the another simulations data. So once you call that library QL Miss, like I have seen the library survival and library survey MCH, similarly if you call the library QL Miss, and after that the sample data we gave as a sim underscore x, it will just, and thereafter if you call at the QOL of SIMX, it will give us the domain wise value like QL, PF, RA, PF, CF, SF, all these domain wise, subdomain wise calculations it will make, and it will give us the outcome for each individual's value. So what happens, each individuals are having different visit wise value, and it will calculate and different scoring value from the QL questionnaires 1 to 30. It will calculate for individuals wise value, and it will give us pass the new data set. So it is going to give us a new data set. Once we are having the new data set, what rest are there? We are having the arm. Arm will be always be come with that, and we can make the arm wise comparison, and we can see the quality of life changes between these things or not.
Atanu, can you just show the?
Yes.
So what is showing you is that if you have entered the data and use this package with this single command, you actually end up whatever calculations which I told you, raw scores, range, division, you get quality of life, domain values, physical functioning, role functioning, emotional functioning, social functioning, all these values, something for dyspnea, something for pain score, all these values in a click, patient wise values are going to come. So this would bring down your job, which would manually would be for few months to a few seconds. Okay, so again, I'll ask him to circulate this, copy that command. That one.
The only single line.
Single line.
Colon and this is you don't need to also head. Head is just showing us first few characteristics, but only if you call QL and SIMX.
Yeah.
QL is a function, and after that CMX, it will give us the result.
So one question: how did you any particular format you want the data to be entered for CMEX?
You have to, one thing
Yeah.
is that you have to give the questionnaires value as Q1, Q2, Q3. Sometimes what happens, sometimes you mix some small q, capital Q, that is not going to happen. Sometimes we say questionnaire 1, column name give questionnaire 1, question 1. No, just put small q1, small q2. If you give, then only it is going to give, otherwise you are not
So
going to get.
did you understand what he said? What he said is when you're doing a quality of life entry, you would have 30 questions. So you would have headings, patient number 1, 2, 3, 4, arm, and this heading for question 1, you just write Q1, small q1 1, Q2, and just enter that. So 1, 2, 3, 4, whatever he has circled, you enter that value. So Q1 to Q30 you would have, plus the arm and the A, and this data, once you entered in this format. So another question is, some patients may have repeated entries, like baseline, 2 months. So do you want them to be done in this format, or you would have like one entry per?
Yes.
Yeah.
So it will be from top to bottom.
So what is again trying to say, and if I'm correct, if I'm wrong, is patient 1 baseline value will run like this.
Yes.
Patient 1 2 months value will run like this. Patient 1 4 months value will be done like this. So even if you have, let's say, 200 patients in your data set, and if they have taken quality of life at 6 intervals or 6 times, your data set will be actually a 1200 rows. Okay, am I clear? Has everyone understood this? So you would have entries which will be done like this, and once you enter in that format, then you can actually, with a click, you can get the analysis done. Another question: if the data has missing values,
Yes.
for using this package, it needs to be entered as NA or 999.
Yes. So if you are having the provision that I mentioned, we are having the provision to put as here. See, here you can, the second one, if you put 9 or 99 or NA, three
Okay.
things stuffs can be taken together. Or another way we can make it, if you want to have the only the observed value you want to discard, if the persons are having partial information you want to discard, we can directly discard
Okay.
those. Only the complete information will be happening with the patient underscore,
Okay.
miss underscore patient.
Okay. Another question is, so what is trying to tell you is, if there is some question which has not been answered by the patient, let's say Q5 was not answered at 5th visit, just enter 99 in that.
Yes,
col-
99, 9 on
no,
NA.
NA.
Don't
Do you need to enter NA, or if you leave it blank when the
No, blank is not
okay,
acceptable.
okay, you need to enter NA. So either you need to put 9, 99 or NA for the function to work.
Yes. So if it is a 999 or NA, it will work. Or another thing that stuff we put over there, if you give some value, let's say questionnaire 1, question 1 is supposed to come between 0 to 4 or 1 to 4. If you give in place of 4, if you write 14, it is not going to accept. So that person is going to be directly, that person's observation is going to be directly discarded. So that's going to happen. So that is not going to allow that patient. So for the simplicity, what happened that sometimes what happened that we could not run the functions because the data is having so many not allowable value, out of the range values are there. So that's why these functions don't work. So to avoid that circumstances, we make it simple. So if the patient, you are giving some not allowable or out of the range value, then it is going to be directly discard that value from that place. So these are the example. Now this now we are there are different type of missingness. That is missing completely at random, missing not at random, or missing at random scenario. Different distribution form of the missingness is there. So we are trying to overcome that. We are trying to understand from the data what type of missingness is there. So in accordingly, the imputation technique will be taken care on that data. So if you are having still NA 9 or 99, that can be overcome by some imputation technique over them. I think I would like to say something about the imputation.
No, I don't want to. HN35 is not yet ready.
It's under process.
Okay. And BN, brain,
Yes, it's under process. So all these things we are working on, mostly done,
please
but it's
finish
not.
the process. We already have some quality of life data which we need to analysis.
So say it's almost done. So means we will put this updated versions. So updated versions can be obtained from this GitHub code. We didn't put in the library right now in CRAN it is not listed now. So if you go to GitHub abstract and then QL miss package, then you will directly install that, and it will work similarly like our other packages work. So we are trying to extend with this all subdomains and like that. So not only the 30 questions, 35 for example, so HNC breast with 29, lung with 13, other questions can be also be separately considered over there. So these are the quality of life. At least we know about the URTC and quality of life data. So we are trying to overcome the challenge over there. So these all things. I would like to end here. And thanks a lot to listen, and I'm privileged to share my experience and all this data analytics and challenges and their interpretation over there. Thanks a lot to Dr. Vijay, all the support you gave.
So what I'll request him to do is, if you can make some YouTube videos of actually using the data code, and if you can give the link, we can share it to them so that they can have a dummy data set and the codes with them so they can practice at home. Okay. With that, the workshop comes to a close, and I invite all of you for dinner.